Welcome to Gastrointestinal Stromal Tumors, How to Understand Your Pathology Report. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. When you submit your question, it will be visible to all panelists, but will not be visible to other attendees. Please remember that information in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the VP of Program Services at the LifeRAF Group, and I am your moderator for today. I would like to introduce our presenter, Dr. Kelsey McHugh. She's a board-certified anatomic and clinical pathologist with cytopathology subspecialty certification, who is currently completing gastrointestinal, hepatic, and pancreatic pathology subspecialty training. She is a new addition to the staff pathology team at Cleveland Clinic, and we're very pleased to have her join us today to present on this topic. Dr. McHugh, you can begin.
Thank you so much, Sarah, for that kind introduction. And as she mentioned, today we're going to be talking about gastrointestinal stromal tumors and how to understand your pathology report. Here's an outline of what we're going to be discussing today. We'll start by reviewing the pathology and molecular biology behind gastrointestinal stromal tumors. Through this review, we'll then see how the components of a pathology report get generated, and we'll discuss what each component means. And finally, we'll close with a review of the ancillary tests that pathologists can order on tissue from GIST tumors and see how those results help guide therapeutic decision-making. So let's start with the basics. What is a gastrointestinal stromal tumor? The gastrointestinal stromal tumor, or GIST for short, which is the abbreviation I'll be using throughout this talk, is the most common human sarcoma with an estimated incidence of approximately 10 to 20 cases per million people. It is also the most common mesenchymal tumor of the GI tract. Typically, these tumors arise in patients greater than 50 years of age, and there is no established sex predilection, so there's a near equal occurrence in both male and female patients. GISTs are thought to arise from precursor cells to the interstitial cells of Cajal, which are pacemaker cells of the gastrointestinal tract. They occur throughout the whole tube that begins from our mouth and esophagus down through our anus. These cells are spindle-shaped mesenchymal cells that are thought to lie within the bundles of smooth muscle that make up the muscularis propria. On the right-hand side of the screen, you see a diagrammatic representation of the components of the wall of the gastrointestinal tract. The main thing we're talking about here that I wanted to convey was that within a nerve plexus, within this thick bundle of smooth muscle, that is where these interstitial cells of Cajal lie in the normal tubular GI tract. While gastrointestinal stromal tumors run the full gamut of biologic behavior, ranging from benign to malignant, it is much more common that these tumors behave in a relatively benign or indolent manner. Ultimately, only up to a third of GISTs demonstrate malignant biologic behavior, with the remaining 2/3 behaving biologically benign or indolent. There are three main morphologies of GIST tumors when we examine them under the microscope. These include a spindled morphology, which is the most common scenario, and you can see that happens in about 70% of cases, an epithelioid morphology, and a mixture of these two previously mentioned cell types. I'll show you what each of these tumors looks like under the microscope momentarily. The distinction between these three morphologies is really only significant for pathologists in ensuring that we understand the many faces of how a gastrointestinal stromal tumor can present under our microscope, and to ensure that we get the diagnosis correct. Each morphologic subtype has its own unique differential diagnosis or host of other tumors that we consider and exclude with ancillary studies when we examine them under the microscope. And that's out of the scope of what we'll be discussing today, but I just want to explain why we feel it's important to distinguish these different morphologies or morphologic subtypes. It's also important to document the tumor morphology in case the tumor should ever recur or metastasize. So it helps to have a written record of what the primary tumor looks like in the pathology report and then subsequently the EMR. Finally, there are some molecular alterations that are associated with different morphologies, and we'll talk about those associations on upcoming slides. So seeing different tumor morphologies can remind you to order specific certain other ancillary studies. And again, we'll review those associations throughout this talk. Ultimately, the morphology of the tumor does not hold prognostic significance itself or anything of that matter. It's really more so for pathologists and physician or clinician communication. So here's what a spindle cell type of GIST looks like under the microscope. You can see that we have these cells arranged in what we would describe as fascicles, or almost like schools of fish that are sort of streaming and intersecting with one another. For these different streaming areas of what probably appears as purple and pink regions on the screen, the purple portions of these cells that are sort of oblong, ovoid, or spindled, that's the cell nucleus. And the pink stuff surrounding it is its ill-defined cytoplasm. It's often described as sort of fibular or ropey in GISTs. So this is what a spindle cell GIST looks like. You can see it's a very cellular or densely cellular neoplasm, a lot of tumor cells lining up together back to back. In contrast, here's what an epithelioid variant of GIST looks like. You can see it has a very distinct and very different morphologic appearance than the spindle type that we just looked at. Epithelioid cells are generally round or polygonal cells, is how we describe them in pathology. And you can see that the purple nuclei in these cells are more round to ovoid in shape, not as elongated or spindled as the last subtype that we looked at. And these cells have more distinct and abundant eosinophilic cytoplasm. If you look, you can sort of see each individual round cell on its own, and that's the polygonal appearance of an epithelioid GIST. With epithelioid GIST, oftentimes they look like this, where it's just a sheet of epithelioid cells. Sometimes they have a more annested appearance, where the tumor cells have these sort of traversing stromal or fibrous bands that wrap around clusters of tumor cells. So in case a picture of your tumor gets included in your pathology report, which many practices do, those are sort of the different ways that this tumor can present. Finally, there's the mixed subtype of GIST, which includes both spindled and epithelioid components. That's what's pictured for you here, with the right side of the screen showing our more typical spindled component, and the left side showing an epithelioid component that has much more white space in between each of the individual cells. And that's what a mixoid background looks like in GISTs. And many epithelioid GISTs do have a mixoid background, and that's portrayed for you here. So just some examples of the many different ways that these tumors can look when we examine them under the microscope. When it comes to the molecular biology of GISTs, there are a number of gene mutations that have been identified as possible culprits that lead to this tumor formation. Approximately 75% of GISTs possess activating mutations in the KIT gene, whereas another 10% have activating mutations in the PDGFRA gene, which stands for platelet-derived growth factor alpha. On the schematic on the left-hand side of the screen, you can see this KIT or PDGFR receptor. It's a tyrosine kinase receptor that sort of spans the membrane of the cell. So this would be outside of the cell or the extracellular domain, and this is inside of the cell. This receptor, when activated, results in signaling in many downstream pathways, some of which are listed for you here, and we'll talk about a few of these components on future slides as well. Ultimately, the important takeaway is that activation of KIT or PDGFR alpha or A results in growth signaling to the cells. So these cells begin to grow, proliferate, enumerate, and that's basically how the tumor forms. Beyond the 85% of tumors that have this constituent activation of KIT or PDGFRA or alpha, there are also wild type GISTs. This accounts for the other 10 to 15% of GISTs, and these are GISTs that lack KIT or PDGFR activation or mutation. So in wild type GISTs, This is sort of an ongoing field of exploration, so it's an ever-evolving group of tumors. But most recently, these wild-type GIST have been divided into two subgroups, the SDH competent GIST and SDH deficient GIST. We will talk first about the SDH competent GISTs. These are GISTs that don't have KIT mutations, don't have PDGFRA mutations, and also lack SDH mutations. When SDH mutations aren't identified, which is the most common scenario in wild-type GISTs, we then go hunting for the less common scenarios. About 7% of these SDH competent GISTs house BRAF mutations, which might be a common gene name to you because it's mutated in many other tumor types, such as melanomas and colorectal carcinomas. Other tumors may harbor NTRK mutations, which is something we'll talk about and for which there is a specific targeted therapy. And then rarely these tumors also harbor NF1 mutations and arise in patients that have neurofibromatosis type 1, which we will also talk about on future slides. In SDH deficient GISTs, this accounts for nearly half of wild-type GISTs, and these are cases in which the SDH complex, which is a complex that is an important component of cellular mitochondria and results in cell energy production, is mutated and thus dysfunctional. In these SDH deficient GISTs, we can actually identify these tumors using immunohistochemistry, which I will talk about and show you on a future slide. And we can also identify them through molecular studies. The vast majority of these tumors arise in the setting of pediatric GISTs, which are uncommon tumors, but the vast majority of them are SDH deficient. We can also see them in some sporadic cases, oftentimes in adult tumors. And then finally, there are two syndromic forms of GIST formation that are actually SDH deficient, and that is Carney triad and Carney-Stratakis syndrome, both of which we'll also talk about on upcoming slides. It's important to note that Carney triad is non-hereditary and results from SDH complex C promoter hypermethylation, whereas Carney-Stratakis syndrome is something you inherit. It's a hereditary autosomal dominant condition associated with specific other tumors that we can discuss on future slides. And these patients have germline mutations in their SDH complexes. It can be in either the B, C, or D complexes. So now let's talk about each one of these mutations individually and try to shed some light onto the biologic and clinical significance of these mutations in specific context of GIST tumors. We'll start with the most common mutation, which are KIT mutations. Approximately 75% of all GISTs harbor a KIT mutation. Both KIT and PDGFR genes each contain 21 exons. However, mutations cluster in different exons within each of these genes. So in the schematic on the left here, we've highlighted for you the exons that are most frequently mutated in KIT mutated GISTs. You can see that mutation clusters occur in exon 9, 11, 13, and 17 in the KIT gene. Exon 11 mutations account for nearly 2/3 of cases, 66%. These mutations can be deletions, insertions, or substitutions. Generally, when we talk about mutations in these different genes and within the specific exons of these different genes, it's not something that holds significance in terms of the type of mutation that's causing the constituent activation or the permanent turning on of this gene. But that is not true in exon 11 mutations. In exon 11 mutations, the deletion of part of the gene that results in its constitutive activation is actually associated with shorter progression-free and overall survival. Beyond that, the other types of mutations that occur in this exon don't hold any prognostic significance. Generally, exon 11 mutated GISTs occur in the stomach in the vast majority of cases. Whereas in exon 9 mutated GISTs, these predominantly are going to be occurring in the small bowel. You can see on the far left here that exon 13 and exon 17 mutated GISTs are relatively uncommon phenomena and typically come about through substitution mutations. These don't have anatomic predilections. Finally, secondary or acquired mutations also typically occur within the KIT gene in the setting of GIST tumors. And what these are acquired mutations that result from exposure to imatinib or targeted therapy. Most typically, these acquired resistance mutations where you get additional mutations within exons that result in a lack of response to the targeted antibody occur in patients that have exon 11 mutations. Next up is PDGFR or alpha mutations. First, it's important to note that KIT and PDGFR mutations are mutually exclusive events. So you won't find tumors that harbor both of these mutations. PDGFR mutations account for approximately 10% of all GISTs, and you can see that the vast majority of these tumors, more than 80% of KIT-negative GISTs, are going to house PDGFR mutations. These tumors typically occur in the stomach and usually will have an epithelioid or a mixed epithelioid and spindled morphology. They generally have a relatively low risk of recurrence, and the mutations that occur within exon 18 actually result in primary resistance to imatinib or Gleevec therapy, and there are alternative drug options that work well in these patients, and we'll talk about that towards the end of today's talk. Our next category of mutations are BRAF mutated GISTs. These account for a small subset, approximately 7% of wild-type GISTs that lack KIT and PDGFR mutations and also lack SDH mutations. These tumors show a predilection for a small bowel location and typically arise in middle-aged females. These tumors are associated with some aggressive histomorphologic and clinical behavior. They often have a high mitotic rate and are associated with early metastasis. Additionally, similar to the exon 18 PDGFR tumors we just discussed, these tumors also often show primary resistance to imatinib or Gleevec therapy. And that makes logical sense because Gleevec therapy is targeting this KIT receptor on the cell membrane. So if you're turning off the activation of this, it's relatively unimportant if you have a downstream part of this pathway that's already constituently on. So in these BRAF mutated patients, it's a mutation happening in this gene here, which is downstream of the KIT receptor that is leading to these cell proliferation or cell growth signaling to occur in this. So it doesn't really matter what you do to the, to the KIT receptor via medication because you've already bypassed that method of turning the gene off essentially. Fortunately, there are specific BRAF inhibitor drugs that are mainly used in malignant melanoma currently clinically, but there are a few case reports that have shown efficacy in BRAF mutated GISTs, and that is certainly something that will continue to be investigated for utility and eventually FDA approval. Next are SDH deficient GISTs. SDH deficient GISTs arise almost exclusively in the stomach and affect predominantly female patients. They tend to manifest in a younger age, and they have pathologic features that are associated with them that are also aggressive, somewhat similar to the BRAF mutated GISTs we just discussed. Under the microscope, these tumors will often have lymphovascular invasion and will be able to identify lymph node metastases as well as distant metastases, typically to the liver or the peritoneum. Importantly, germline mutations in any of the genes encoding the SDH subunits can lead to different tumor types or many other tumor types in addition to GIST tumors. Examples would include paragangliomas, pheochromocytomas, SDH deficient renal cell carcinomas, and pituitary tumors. So patients who are identified as having SDH deficient GISTs should also be screened for other tumors, particularly if their SDH deficiency has been shown to be a germline mutation rather than a somatic mutation. Ultimately, about 50% of SDH deficient GIST patients do harbor germline mutations, and it's most commonly the A subunit that is inactivated. For SDH complex, there are a total of 4 subunits that work together to result in this signaling you see here, the A, B, C, and D subunits. Mutations can occur in a long list of exons in each one of these different subunits, but the vast majority of the mutations that occur are substitution type mutations. Finally, we have NF1 mutated GISTs. These are very rare. NF1 or neurofibromatosis type 1 mutations are an inherited autosomal dominant condition that results in the clinical disease neurofibromatosis. Patients with NF1 will generally present clinically as having café au lait spots, which are sort of pale brown splotches on their skin, as well as leash nodules, which are dome-shaped gelatinous masses that develop on the surface of the iris of the eye, in addition to freckling of the skin, and then subsequent development of neurofibromas. Neurofibromas often clinically present as subcutaneous nodules in the skin, and it's a proliferation of bland neural components that occurs in the dermis. When GISTs arise in NF1 patients, a minority of those cases are actually NF1 mutated GISTs, only about 7%. So for patients who have a diagnosis of neurofibromatosis type 1 and subsequently develop a GIST, it still is of importance to perform the typical KIT and PDGFRA mutation analysis in order to make sure that these tyrosine kinase inhibiting drugs may be to determine if they may be of utility in these patients. Because again, only a minority of these GISTs that actually arise are due to NF1 mutations. It's a very uncommon scenario. Okay, so now that we've covered the microscopic and biologic genesis of GISTs, let's talk about them on a more macro level. When GISTs arise in your body, where do they most typically occur? Generally, as the name implies, GISTs arise in the gastrointestinal or GI tract. You can see that by far and away, the most common scenario is that they arise in the stomach, with the second most common location being the small bowel. Remember that the small bowel is composed of the first part, which is the duodenum, the second part, which is the jejunum, and the third part, which is the ileum. You can see that second and third part involvement is much more common than duodenal involvement for these GISTs. That's challenging because the duodenum can generally be examined via upper endoscopy and easily reached with a needle for biopsy or sampling, whereas jejunum and ileum are harder to accomplish that with. The least common scenarios are involvement of rectum, colon, and esophagus. You can see with decreasing frequency here. And in very rare instances, gastrointestinal stromal tumors can arise outside of the gastrointestinal tract. And generally when this occurs, they arise in the omentum or the mesentery. Finally, one last type of clinical presentation, which is also rare, is where GISTs present as a disseminated tumor without a known primary site. And it can be very hard to discern which lesion represents the primary or initial lesion in those situations. Once a lesion is identified, either on imaging or endoscopy or physical examination, how do we then reach a diagnosis of GIST? Sampling of the tumor is the necessary first step in order for a pathologist to render a diagnosis. There are a few different ways your clinicians may suggest going about collecting tumor material for pathologic diagnosis. For very small GISTs, generally GISTs that are less than or equal to 2 centimeters in size, they might or likely will suggest fine needle aspiration, which is abbreviated as FNA. FNA is where a very thin needle is inserted into the lesion and moved back and forth at a relatively rapid rate in order to slough cells out of the lump or bump and into the needle bevel. We then essentially squirt those cells out onto a slide in sort of a liquid format, let them dry, and then we look at them under the microscope with a stain. For tumors that are bigger than 2 centimeters in size, the more traditional needle biopsy is typically what's undertaken or what's performed. A needle biopsy, either a fine needle biopsy or a needle core biopsy, a fine needle biopsy has a slightly smaller caliber than a needle core biopsy, will both produce intact tissue fragments that we then fix in a fixative solution and cut into very thin pieces to be able to examine them under the microscope. And the nice thing about needle biopsies is that it generally does collect more material than fine needle aspiration, though that's not always the case. Finally, if the tumor is in a very easily resectable location, your clinician may suggest just initially beginning with primary resection rather than sampling, because regardless of what the lesion comes back as, if it's symptomatic or it's in some sort of anatomically not ideal location, it will need to be removed anyway. Once we have tissue to examine under the microscope, pathologic features that are considered significant prognostic factors are listed for you here on this slide. I'll show you how the first 3 of these factors directly play into the assigned prognostic score on an upcoming slide. For now, suffice it to say that the risk of malignant behavior varies per anatomic site, which is why it's so important to know where these tumors are specifically arising. Gastric GISTs generally behave more indolently than GISTs of the small bowel, colon, rectum, mesentery, etc. The size of the tumor also directly affects its prognosis. Generally, tumors less than 2 centimeters in size typically behave indolently or benignly, whereas tumors that exceed 10 centimeters in size are more likely to be bad actors. And of course, there's sort of a spectrum of behaviors and sizes that fall in between those 2 extremes. Additionally, histologic grade is an important consideration in sarcoma staging and is determined by counting the number of mitotic figures in a given surface area of a tumor. The cutoffs for what counts as low versus high mitotic rate varies per tumor type, as does the surface area that's to be assessed. For GIST tumors, a low mitotic rate, which is equivalent to a low histologic grade, is 5 or fewer mitoses identified in a 5 millimeter square area of tumor. High is anything over 5 mitoses in that same surface area. Finally, there's tumor rupture. Though this is sort of a vague descriptor, if the tumor is found to have ruptured either in situ before you presented for clinical management or during the surgical procedure, this is known to be associated with an increased risk of peritoneal seeding or recurrence. So the presence or absence of tumor rupture is another important prognostic factor that should be considered. In the world of pathology, we currently stage GISTs according to the 8th edition of the AJCC Staging Manual, and I put a picture of the cover of that book for you here. While the National Institutes of Health or the NIH also do have their own unique staging system for GISTs, the AJCC staging system is based on the largest retrospective series of GISTs to date and is thus our preferred staging system. It's used by pathologists and clinicians alike. It's also the recommended staging system by our governing body, the College of American Pathologists. It's important to note that this staging system should not be applied to things such as pediatric GISTs, familial GISTs, and syndromic GISTs, as these are all rare subsets of GIST that typically behave extremely indolently. So you may overestimate the bad behavior of these tumors by using this staging system. Rather, all other GIST types are safe to be staged with this system. So there are just a few exceptions to the rule. And again, these are the very rare tumor types. As with all tumors, the AJCC stages GISTs using a TNM staging system. It's easiest to remember what TNM stands for by just thinking of the single word that it associates with. So T is for tumor, N is for node, which is lymph node, and M is for metastasis. But how do we define each of these components? We'll start with the definition of T, or primary tumor size. The T stage is based solely on the size of the lesion. It's either determined via imaging or at the time of resection. If we're defining it in pathology as a pathologic stage, then it must be at the time of resection. You can see here that our important cutoffs are 2, 5, and 10 centimeters. If tumors are 2 centimeters or less in size, then they're staged as a T1 lesion. If they're more than 2 centimeters in size, but do not exceed 5 centimeters in size, then they're staged as a T2 lesion. If they're more than 5 centimeters in size, but less than or equal to 10 centimeters, then they're staged as a T3. And if they exceed 10 centimeters in greatest dimension, then they're staged as a T4. When the size of a tumor is based on the pathologic assessment of tumor or measurement of the tumor after it's been removed from the body, lowercase p will be placed in front of this capital T with its associated number. If this value has been determined just based on imaging prior to it actually being resected, then a lowercase c for clinical will be placed in front of it. The next thing is the N stage, or the regional lymph node stage. You can see that the N category is more simple than the T stage we just reviewed. There are only 2 subcategories for regional lymph node involvement. It's either there is regional lymph node involvement, so there's tumor identified in lymph node, or there's not. If there's not, it's an N0. If there is tumor, it's considered an N1. Of note, nodal metastasis is extremely rare in GIST. There are, of course, exceptions to every rule, and the exception to that rule of it being extremely rare is that it does happen in SDH deficient GISTs, like we talked about when we were reviewing the molecular biology. Finally, we have the M component of TNM staging, which stands for distant metastasis. Again, this is a simple binary division. M0 means there's no distant metastasis, and M1 indicates that there is. Generally, if this is being pathologically assigned, we don't assign it based on presumed radiologic findings of lesions that represent metastases, but rather the lesion has to have either been biopsied and submitted with the resection, or also resected itself, so a metastatic resection as well. So again, this is pathologically defined by what we receive in the lab and what we can confirm definitively under the microscope, and is not based on any degree of assumption. When GISTs do metastasize, which is not that common of an occurrence, the most common sites of metastasis are either the liver or the peritoneal surface. There are a few more modifications we make to the TNM pathologic staging system, which includes a set of prefixes and suffixes, because we can never keep it simple in the world of medicine. So in case you encounter any of these in your pathology report, I wanted to just very briefly cover them. The M suffix gets placed after your T stage if you have multiple primary tumors at a single anatomic site. An example would be if you have 3 separate or multifocal GIST lesions within a single segment of small bowel, or within your small bowel. This would count as multiple primary tumors in a single anatomic site or organ and would be designated with an M. The Y prefix gets tacked on if a pathologic evaluation of your tumor is occurring after you've received neoadjuvant therapy. So if they treat you with a biologic agent first, such as a TKI, and then they resect your tumor, we'll confirm that there's post-treatment effect in your tumor and designate this a Y lesion, or a post-treatment lesion. This is important because after treatment, there can be degrees of necrosis and fibrosis that sort of obliterate or eliminate parts of your tumor, which can affect the different sizes and pathologic parameters that we report in our synoptic reports. Finally, there is the R prefix. This is used when your tumor has recurred after a well-documented disease-free interval. So should this occur and you undergo repeat resection, your new tumor stage will have an R at the beginning to indicate that it's a recurrence. So this is what those letters look like in actual practice. So again, for the M, it goes after your T and the T's associated number. And then the Y and the R are prefixes that go before the lowercase p, which is what's indicating to you that this is a pathologic staging system and not clinical. When we convert all of this grading and pathologic staging information into prognostic information, it becomes extremely meaningful for patients and for clinical management and therapeutic decisions. This is the complicated table that gets generated when we sort of attempt to synthesize all of this important information. And what you're seeing here is an offering of statistical probability of the degree of recurrence or metastasis in these tumors based on histologic pathologic parameters. You'll notice the AJCC staging system currently does not incorporate mutation status into this table of prognosis anywhere. And that is something that will certainly change, I'm sure, in the coming years as we learn more and more about these tumors. But for now, all of the prognostic factors are all based on clinical and pathologic evaluation. So the three main things that get considered when you're giving a risk of progressive disease percentage to patients is, where does the tumor occur? So here in this top row, you can see gastric versus different locations within the small bowel versus the rectum. How big is the tumor? And here you can see the different size cutoffs, which are the same as what were used in our T staging, so T1, T2, T3, T4. And then finally, what was the mitotic rate? Was it a low mitotic rate or a high mitotic rate? Basically, you can march through this table based on the parameters within your pathology report, and you can see your risk of metastasis or tumor-related death in subsequent years. You'll notice that the vast majority of tumors, many of the tumors have very low to low risk. In some boxes, there is insufficient data for us to offer a prognostication as to how these tumors behave, and that's generally because these tumors are, the set of parameters within these tumors is uncommon, and there are too few cases to really develop any sort of statistical meaning or significance out of what we know so far. For anatomic sites that aren't listed in this table, you'll notice that there's no esophagus, there's no mesentery, there's no peritoneum, there's no omentum, or in any case where you can see an insufficient data documented, it's best to use the risk criteria for jejunum ileum in that setting. So basically just assign your tumor as belonging to the jejunum ileum and go to the associated size and mitotic rate, and then use that percentage of subsequent risk of metastasis or death due to disease. Don't forget that the pathologic grade and stage will then be converted into a clinical stage, and this is the stage that patients that have neoplasms use to communicate with one another and with their oncologist. So this is the typical stage 1, 2, 3, or 4 tumor or cancer. So here we're looking at this clinical staging system for GISTs of the stomach. You can see here that different collections or groups of tumor sizes are combined with either their mitotic rates or the presence or absence of any nodal or distant metastases to ultimately be put into one of these 4 staging options. For example, you can see here that any tumor that is less than or equal to 10 centimeters in size, so T1, T2, and T3 tumors in the stomach that have a low mitotic rate, those all get placed into stage 1. So that's a really broad range of tumors. In contrast to that, any tumor that has either lymph node or distant metastasis, regardless of the size of the primary tumor or its mitotic rate, is automatically a stage 4 disease. Here's the clinical staging system for small bowel or small intestinal gastrointestinal stromal tumors. And you can see that the rules are slightly different here. T1, T2, and T3 lesions are now separated out into stage 1 and stage 2 instead of all being part of the stage 1 category when they have, low mitotic rate. I know it is confusing that we convert a pathologic stage, TNM stage, into an overall clinical stage, and then we communicate using all of these different types of stages. And it's nearly impossible to remember the different combinations of TNM factors that will result in different clinical stages. So the NCCN has put out this useful table such as this that you can refer to should you ever get sort of confused or bogged down with the details. So once we have a diagnosis we've rendered a diagnosis of GIST, what are useful ancillary studies that we can perform in order to provide patients with the most meaningful and therapeutically impactful information? The 2 main things that we do in the pathology laboratory are immunohistochemistry and molecular analysis. So let's talk about this. In these guidelines put out by the National Comprehensive Cancer Network, you can see that for all GISTs, greater than 2 centimeters in size, that's what this category is, they recommend that tissue sampling is performed to confirm the diagnosis. Once we have that tissue, we use immunohistochemistry to render the diagnosis. And we'll discuss the different immunohistochemistry, which is abbreviated IHC, on the next slide, because it's certainly words that you'll see in your pathology report. Interestingly, immunohistochemistry can actually also be used as a screening test for SDH deficient GISTs that lack KIT and PDGFR mutations, because there'll be a loss of expression of this stain or a marker that we can visualize under the microscope for any SDH deficient tumor. You can see that the other ancillary testing they recommend is mutational analysis for KIT and PDGFR. That's always step one in these tumors, especially if your clinical treatment course is considering using a tyrosine kinase inhibitor. Of course, should your tumor come back without any KIT or PDGFR mutations, additional mutational analysis for things like SDH gene mutation, as well as the other gene mutations we discussed earlier, including BRAF and NF1, as well as NTRK, can also be performed. So let's talk about immunohistochemistry for a minute and sort of decode the letter and number soup that is IHC. Because of the advent of these tyrosine kinase inhibitor therapies that are so efficacious in GIST tumors, it's extremely imperative that as a pathologist, we get this diagnosis correct so that patients get the subsequent correct treatment. The IHC is the integral part of working up these tumors because, as I mentioned on earlier slides, these tumors that have either the spindled or the epithelioid morphology look like a lot of other tumors under the microscope. The interesting thing about GISTs is that the vast majority of cases are going to stain positively with c-KIT, which is synonymous with CD117. It might be how it's written in your pathology report. So you can see that about 95% of cases are going to strongly and diffusely express c-KIT. And that's what I pictured for you here on the right side of the screen, just so you understand what an IHC marker looks like under the microscope. What IHC is it's antibodies to parts of these genes or proteins that have been mutated. And if the mutation is present or the expression is present, these antibodies will attach to that. And then we essentially attach a chromogen or a color to the antibodies. So if the antibody successfully attaches to a tumor tissue, indicating that it has expression of a certain protein or gene, then we see this brown color under the microscope. If this were to not express c-KIT, all of the cells would look like this pale blue stuff in the background that didn't stain. Other markers that you'll see listed in your pathology report include DOG1 and CD34. DOG1 actually stands for discovered on GIST1 and is a protein that is relatively specific, though not entirely, to GISTs. And as you can see, it's expressed in the vast majority of GISTs. CD34 is a non-specific marker. It's actually a vascular marker or a marker of endothelium in most scenarios, but you'll see that the vast majority of GISTs do express CD34. So your pathology report should be confirming for you, either with one or multiple of these stains, that your tumor is strongly and diffusely expressing these different proteins. We won't get into the names of the other tumors that we consider when we're looking at a GIST, but suffice it to say that there are markers that most pathologists will perform to exclude these other tumors that can look exactly like a GIST under the microscope. So generally, you'll see confirmation in your pathology report that your GIST tumor is negative for SMA, which stands for smooth muscle actin, desmin, H-caldesmin, S100, and keratins. Keratins are markers of epithelial differentiation, so there's something that like a carcinoma would express rather than a sarcoma type tumor. Of course, these markers aren't always negative, so I don't want to drill this into your mind as a hard and fast rule. And there can be focal, sort of patchy, weak expression of all of these markers in GISTs in small percentages of tumors. The most frequent marker that does get expressed to a minor degree in GIST is SMA, which you can actually see in around a third of GIST tumors. whereas Desmond and H-Cal-Desmond and S100 all are happening in 5% or less of tumors where you might get patchy focal positivity. So these are all just sort of confirmation studies that we do to confirm that our morphologic impression is correct and we're rendering the correct diagnosis. As I mentioned before, SDH deficient GISTs can also now be screened for by using SDH-B immunohistochemistry. No matter which of the 4 subunits is mutated in SDH deficient GISTs, all of the tumors lose immunohistochemical expression of SDH-B. So we can actually perform this immunostain, which is significantly cheaper than performing a molecular test, and use it as a screening method for identifying these deficient tumors. And many groups are now advocating that if you have a gastric GIST, and especially a gastric GIST with epithelioid morphology, that all of these tumors should be stained with SDH-B IHC, because most typically these SDH deficient tumors do present in the stomach and do present with an epithelioid morphology. When it comes to molecular testing in GISTs, step number 1, as we've mentioned multiple times over today, is to perform KIT and PDGFR mutational analysis, especially if your treatment plan is possibly going to involve tyrosine kinase inhibitors. It also helps to set a baseline as to the primary mutations that exist in your primary GIST tumor, because remember that if you do ever undergo therapy, that resistance mutations can arise, and it can be hard to discern what represents a resistance mutation versus what mutation was inherent to your tumor prior to its exposure to therapy or treatment modalities. If KIT and PDGFR mutational analysis comes back negative, the next step is working up that wild type GIST, which is what we call GIST that lack KIT and PDGFR gene mutations. And as we've mentioned multiple times today, this involves performing SDH-B IHC, as well as potentially doing the mutational analysis for SDH gene mutations, as well as looking for BRAF gene mutations, NF1 gene mutations, and potentially performing general genotyping, which is just looking at your entire genome, or all of the genetic material that makes you up, to see if there are any specific genes within your tumor that have become mutated and that might already have a targeted therapy available to them. And I'll show you an example of that in some of the FDA-listed drugs that exist on an upcoming slide. On this slide, I've listed for you all of the FDA-approved treatment options for GIST and their relation to disease type and molecular findings. The first 5 drugs that are in this dark blue are all of your standard tyrosine kinase inhibitors. As everybody knows, imatinib was the first FDA-approved drug for the treatment of GIST and greatly extended the lifespan of GIST patients. It's typically the first drug that's used to treat GIST, barring a few examples, which we will review, and can also be taken on a long-term basis should recurrent or metastatic disease develop. Sunitinib is another common TKI that is generally used after imatinib and is attempted if imatinib is not successful in terms of generating a response within the tumor, or if the side effects of imatinib are too negative to continue the therapy. Sunitinib is also the preferred first-line drug for SDH deficient GIST, which you'll remember we discussed early on in this talk. The next drug up is regorafenib, and this drug, along with ripretinib, which is the last drug on the list, are both TKIs that are generally reserved for more advanced or late-stage GISTs, in which treatment with imatinib, sunitinib, and other TKIs has been attempted without success. Finally, there's avapritinib, sorry for my pronunciations, and this is another TKI that has a specific association with a molecular alteration. And I want to highlight the 2 drugs that are associated with specific molecular findings for you here, and that was sunitinib, which we just discussed, and now avapritinib. And this drug is the preferred TKI for tumors that have exon 18 PDGFR mutations. Finally, at the bottom of the screen, you'll see lorlatinib. And this drug in green is also a tyrosine kinase inhibitor, but it's targeted at a different target than the remainder of the drugs listed here. It's targeted at the neurotrophic receptor tyrosine kinase, or NTRK gene. So the inhibitor of this gene was recently approved by the FDA for any tumor that houses this mutation. So this mutation isn't common in sarcomas. It's found in less than 1% of sarcomas, but it's certainly worth investigating as a sort of last line agent, because patients have patients who have NTRK gene mutations within their tumors, relatively regardless of tumor type, respond very well to inhibition with this drug. So on the rare chance that your GIST may house an NTRK mutation, it's worth looking into. And again, these NTRK mutations are going to be found in GIST that lack mutations in anything else we've talked about today. Of course, we perform all of this aforementioned immunohistochemical and molecular testing because it's related to prognosis and therapeutic options. And as you all are aware, identified KIT and PDGFR mutations serve as excellent targets for these tyrosine kinase inhibitors. So here's just a brief review of everything we've talked about, sort of summarized, but based on the molecular finding and its relationship to drug rather than drug to molecular, so maybe a little bit less overwhelming as a list. Again, we know that we always look for KIT and PDGFR mutations because of the utility of TKI and their excellent efficaciousness when one of these two genes is mutated. In the less common scenario where patients have an exon 18 PDGFR mutation, we know that avapritinib is preferred over the standard imatinib. For SDH deficient GIST, we again know that we prefer sunitinib over imatinib because oftentimes these GISTs will also have primary resistance to imatinib therapy, similar to the PDGFR exon 18 mutations. And then finally, don't forget that secondary or acquired mutations that result in resistance of tumor to the drug do occur. It's usually in the setting of long-term imatinib treatment, and typically patients who develop resistance mutations have initial primary GIST mutations that involve exon 11 of the KIT gene. The resistance mutations that form in these GIST patients will typically occur in exons 13, 14, and 17 of the KIT gene. So now I just wanted to give a brief summary. I know that was a lot of information, but just a reminder that the main features that you should look for within your pathology report to sort of know the most important components of your tumor and how they relate to tumor prognosis are the location of the tumor, the size of the tumor, the histologic grade of the tumor, which should be given as a mitotic rate, whether or not there was tumor rupture, and that's oftentimes more of an intraoperative finding rather than something that will be within your pathology report, but if it is noted in the report, it would likely be in the comment section. Don't forget that margin status is relatively important. GIST tumors are often relatively well circumscribed lesions, and surgeons are able to get clean margins when resecting these lesions, but if a margin is involved by tumor, that does change subsequent therapeutic management decisions, and the margin status will be reported within your pathology report. And then don't forget to look and make sure that IHC was performed. It's an important step in confirming the diagnosis, and I know very few pathologists, maybe none, who would render a diagnosis of GIST without having performed IHC. And finally, follow up on whether molecular studies were ordered. One of the negative sides of molecular studies is that oftentimes they're going to be ordered at the time that a final pathology report is rendered. So the molecular data won't be integrated into that initial final pathology report, but rather that report will get updated or addended once the molecular results are available. Turnaround time for molecular studies is extremely variable depending on where you're being treated. At some academic medical centers that serve as reference laboratories for the country, it might only be a day to a few days, but in many hospital systems that don't have access to enormous labs on site, they're going to have to send out material for molecular testing, and turnaround time can be on the order of days to weeks. Finally, Things to discuss with your oncologist. Remember that your oncologist is going to talk to you in the world of clinical staging, and that's when we convert those pathologic TNM factors and the histologic grade into a clinical stage, stage 1 through 4. So remember to discuss that with your oncologist. Margin status is always important, especially if there's a positive margin, and that will affect therapy decision making, so pay attention to that. And finally, make sure that your oncologist is on board with molecular analysis that's being conducted and is receiving those reports, especially if they're being performed as send-out testing. The key takeaways from today are that GIST is the most common mesenchymal tumor of the digestive tract and the most common human sarcoma. GIST is a diagnosis that's made by pathologists who look at tissue under the microscope. So while you might receive a radiology report or your endoscopist might tell you, oh, you have a submucosal nodule that looks like a GIST, remember the diagnosis isn't final until a pathologist has actually reviewed tissue. Remember that GIST is both pathologically staged and clinically staged, and that these are two different things, and that the pathologic grade and stage plays into the final clinical stage. And then don't forget that pathologists are going to be performing a lot of ancillary studies that will be important in terms of making sure you got the right diagnosis, and then also in working up the molecular underpinnings of your tumor to make sure you get the best treatment possible. So make sure that those tests were performed or are being performed on your behalf. Finally, don't forget that the molecular findings in your GIST may contribute to therapeutic decision making. That's not always the case, but it's certainly possible. And as we continue to evolve into a more personalized approach to medicine, this will certainly become more and more true with each passing year, and the more that we learn about the biomarkers that are important in the genesis of GIST. And with that, that is everything. My email is here in case you have any questions that you would prefer to send to me in writing rather than ask in this forum. And thank you guys very much for your time.
Thank you very much, Dr. McHugh. This is a great presentation, very informative. We do have a number of questions that came in. I know we are close to the end of the hour, but I'm going to spill over a bit so we can ask them. Before I proceed, I just want to point out, I know you had mentioned in your presentation about the SDH B staining, how it's relatively cheap. It was a great collaboration that the LifeRaf group did with one of your colleagues, Dr. Brian Rubin, where we were able to see about getting that staining done up front and incorporated in the College of American Pathologists guidelines. So I encourage pathologists to start doing that because why not do it up front at the beginning for all gastric tumors? So just a comment there.
Yeah, I wholeheartedly agree.
And then also regarding the larotrectinib, the Vitrakvi, I want to also point out, I think it may be approved for the fusions rather than the mutations. So I just want to make sure, sometimes people kind of confuse a fusion versus a mutation. So just want to make sure we can clarify that. And then also, we may have skipped over, there is actually also a fourth line treatment made by a company, Deciphera, called ripretinib, also Kinlock. And so I don't know if you want to make a quick comment about that, but I know that there's also some further studies looking at that at second line, but that is another treatment that is available for our GIST community. So moving on to some questions. First, what does germline mutation mean? Does that mean the cells mutated when the person was in utero?
No, it doesn't. So germline mutation is something you actually inherit. So there was no mutation of the cells once you were being sort of formed or created, but rather you inherited the genes in those mutated forms from your parents.
Great, thank you. And what if the tissue pathology report shows KIT mutation, exon 11 deletion, but the liquid biopsy shows SDH A mutation? What does this mean?
That would be challenging to reconcile. Generally, tissue biopsy would be, at least currently, would think that tissue biopsy would be considered the gold standard. Using liquid-based material is certainly happening more and more frequently with every passing year in pathology, which is excellent. Especially I practice cytopathology too, and we're often using liquid material to do molecular studies. But when we are validating molecular studies on liquid-based biopsy material, we're using tissue as the gold standard of what is true and real. Repeat testing of additional biopsy or formalin-fixed material would probably be the best step to discern which of those findings represents the real or true finding. But I would rely on the tissue material findings over the liquid-based biopsy findings until further investigation is done. Interestingly, with the IHC, you could also perform SDH B immunohistochemistry as a step on the tissue material itself and see if it's lost. No matter which SDH subunit is mutated, all 4 of subunit mutations will show SDH B IHC loss on formalin-fixed paraffin-embedded tissue under the microscope. So that could also be used as a tiebreaker, is not the correct word, but as a way of adding evidences to one side versus the other.
That's very helpful. Just kind of going along the hereditary piece, how can patients get tested for hereditary concerns? Yeah.
So I only know, I've done all of my training at the Cleveland Clinic, so I really only know the way that we do it. But if there are hereditary or genetic concerns for something that you inherited, we generally would refer patients to a genetic counselor at the Cleveland Clinic. And I would think that if a genetic counselor is not available at the hospital that you're being treated at, that your clinician could certainly refer you to a genetic counselor at whatever the largest nearby academic institution is. So generally, a genetic counselor will perform a whole host of screening with you and determine which testing is the appropriate testing to do to further investigate your concerns. The world of genetic testing is challenging because many of the tests are extremely expensive, and many of the tests are not yet guaranteed to be covered by insurance. So it's generally not something that a clinician or an oncologist or any other sort of treating physician is going to perform on their own, because they might put you in a bad situation where you have extremely large medical bills. So you always want to go to a genetic counselor in those situations.
And just to kind of further on that, if somebody wants to test about an epi mutation or do a methylation testing, how does one go about doing that? Is that standard at a local institution?
Probably not. So it depends on, there are some epigenetic alterations or methylation studies that are more common practice. For instance, there's one that I order, probably a few times a week on different colon cancer tumors. So it just depends on the type of study you're looking for, how common the epigenetic alteration is, and really access to a reference laboratory, because likely a community hospital won't have that kind of testing. But epigenetic analysis can be performed in a lot of different ways, and a lot of more inexpensive ways as well, even including things like PCR. So that is something that is more available in terms of orderability on like the pathologist's front or the clinician's front, and might not require genetic counseling to get that performed.
Okay. There was also a question about who should order the molecular profiling, the pathologist, surgeon, or oncologist?
That's a great question. And I'm sure it varies depending on the institution. At our institution, the treating oncologist has to order the molecular testing, but then obviously everything is conducted in the pathology laboratory. So a lot of times if there's a molecular test that we want to do that we want to ensure we get reimbursed for, we'll actually reach out to the oncologist and have them place the order in Epic to sort of, close the loop in a way. So it's really, it's going to be institution and policy dependent based on where you're getting treated. But if you talk to any 3 of those clinicians, we certainly all communicate frequently with one another and would be able to work together to get that accomplished. So from a patient perspective, interfacing with any one of us would accomplish the goal.
Okay, great. Also, one person reported that they had a 2-centimeter exon 11 just outside the stomach and was resected with an insertion and not a deletion. They wanted to know the difference in the future outcome of insertion versus deletion, possibly as far as recurrence.
Yes. So exon 11 is that one scenario where the type of mutation does I guess, hold or carry a prognostic significance. So for those patients, exon 11 deletions actually carry a reduced progression-free and overall survival in patients, whereas that same association doesn't exist for insertions. So for insertions, it's sort of the status quo prognostic risk that would be generated from looking at your pathologic grade and stage and using that complicated table that we looked at. Whereas if they had had a deletion, that would have held a little bit of a negative prognostic effect on their tumor.
Okay. I think that covers it for the questions, and thank you for sharing your email. So if anybody has any follow-up, they can reach out. Before we close the meeting, for those who are still online or who will be listening to the recording, I'd just like to share that the LifeRAF group is very excited that we will be launching an exciting project that will help identify key scientific questions in the GIST community as it relates to this topic of different subtypes. So just please look out for a press release in the coming weeks for that, and just stay tuned to our messaging so you can learn more. And with that, I'd like to definitely thank Dr. McHugh for your time today. I think your presentation was very clear and informative, something that I think many of us will probably go back to as a nice reference to remember some of the terminology that's being used in our GIST world. And so I want to thank you for your time, and to everybody else, have a wonderful day.
Thank you so much for having me.